Hello, everyone. Thank you for joining Dentistry Today's Direct Composite webinar, sponsored by Tokiyama Dental America. My name is Matt, and I will be your host for today. If you have any questions after the webinar, please type them in the Q&A box to the right, and I'll try to cover as many as possible at the end of the webinar with the remaining time that we may have. This webinar is being recorded and it will be available on Dentistry Today's website along with dentalcetoday.com in about a week after this event. I would now like to introduce Dr. Mark Clive, who is our speaker for today. Dr. Clive, take it away.
Thank you, Matt, and thanks everyone for joining me for today's session. Today we're going to talk about using an appropriate composite for your office, for your dental practice. And just to thank Tokiyama for allowing me to share some information today. I do want folks to know that I don't have a financial connection with Tokiyama or any other company that's mentioned in today's program. As Matt mentioned, my name is Mark Clive. I am a 1997 graduate from the University of Minnesota and now a resident in the Asheville area of North Carolina, the western mountains of North Carolina. So I have been in practice for 22 years. I am in a full-time practice and with a fantastic team of 6 ladies. I have 2 hygienists, 2 full-time hygienists. I have 2 full-time dental assistants, and I have 2 full-time folks that manage the administrative parts of my practice. And so we have predominantly an adult restorative dental practice, and again, kind of full-time. So we're busy from 7 to 3 Monday through Thursday. Just for those of you that don't know what Western North Carolina looks like, the Blue Ridge Mountains, the Blue Ridge Parkway comes through the Asheville area. And so outside my front door, even of my dental practice, this is kind of the views that you can see of the existing area. Like many of you, as a dentist, full-time dentist, I show up at work every day and I have my day plans. I have my schedule plans. My team and I meet and we say, this is what we expect that we're going to see for the day, working with patients, doing the different clinical procedures. The hygienists will have their own part of their practice, but I really have my day planned out well and what I can expect. And I imagine that it's going to be slightly uphill, and we'll put in our work and we'll end our day and everyone will be happy. And the reality is I am just like every other dentist out there, and in most cases my day turns out different than what I expect. So maybe a patient relationship doesn't go as I would plan it. Maybe a clinical procedure doesn't go as I plan it. And that is the world of dentistry that we live in. So I just want everyone in the audience to know that I really am practicing in the real world, and some things go as planned and some things don't always go as planned. And with 22 years of experience, I believe that I am developing more wisdom. This is one of my favorite quotes, that we learn wisdom first by reflection, second by imitation, and third by experience, which is the bitterest. So what I'm going to share with you today is based upon 22 years of experience of things going well and things not going well. To give you an idea of today's direct composite webinar, I want to give you an idea of what it's like in my practice from the standpoint of what procedures do we do, how many of them do we do, Many of you may not have run a report that looks like this, so I'll share it with you, at least from my perspective in my own practice. When I look at the numbers of composites that we do, the frequency that we do direct composite in my practice, and I run the numbers from, these are numbers from 2018, and you'll see the different types of filling materials in the ADA codes that are used. When I totaled these numbers up, what I found out in 2018 is that we did roughly over 1,000 fillings, and those 1,067 fillings had a total of 1,630 surfaces. So, again, as a full-time dentist, we are all doing a fair amount of direct composite dentistry in our practices. So as I talk about my wish list for composite materials and talk about being able to do them efficiently with time, these are procedures that all of us are doing quite a bit in our practices. And so the materials that we use and choose, the techniques that we use and choose, need to have some efficiency associated with them. I'm going to share with my experience as a clinician for 22 years, knowing that depending upon where you are in the world, based upon the techniques that you have access to, the materials that you have access to, your experience may vary. And that's, again, just part of this wonderful world that we live in dentistry as practitioners. I really have three course objectives for our time today. The first is that we examine the best practices to shade, match anterior teeth. I'm going to review with you composite materials and techniques that produce the most natural looking restorations. And I also want to share with you at least my understanding of the characteristics of modern composite materials and how they can contribute to efficiency for us. So when I think of my wish list for composite materials, one of the things that first comes to mind is that any composite material that I use, I would like there to be fewer steps for placement. I would like to have less inventory of materials to manage and purchase. I would like the materials that I use to be highly aesthetic. I would like their handling characteristics to be dependent upon where they're going to be used. Like in some clinical situations, I like to use materials that have less viscosity. In some situations, I want to use materials that have more viscosity. And of course, I want the materials to be durable over time. So I'll come back to this wish list, but in my world, this is what I'm thinking about when I choose the composite materials that I want to choose. The ones that I want to use, these are the things that I'm thinking about. When we look at longevity of direct and indirect restorations and look at what the clinical research is telling us, this is basically a study of studies, and what they found was that the survival of direct and indirect restorations in posterior permanent teeth, that composite material is actually a very sound material for us to be using on stress-bearing areas of posterior teeth. So if you look at the failure rates of amalgam is 3%, the failure rate of composite is direct composite is 2.2%. The reality is today composite material is a very appropriate material for us to be using with posterior teeth. I will note that based upon the information in the study, gold was still the gold standard at 1.4%. But again, direct composite materials are fantastic materials for us to be using even in stress-bearing areas of posterior teeth. With regards to composite materials and what they're made of, every composite material on the market today consists of an organic resin matrix, filler particles, and a coupling agent. The properties of every single composite on the market are really determined by the characteristics and the mix of these matrix and filler particles. And actually, the composite's classification is going to be determined by its particle size of the filler, and the filler characteristics are what provide the translucency, the strength, the opalescence, the radioopacity, and they're what reduce shrinkage. So when we look at composite materials and how we evaluate them for longevity, there are basically 6 characteristics that we consider. The first is wear. Obviously, we want composite materials to have excellent wear characteristics. Water absorption, we want to use composite materials that absorb as little water as possible. We want shrinkage stress to be as low as possible. We want flexural strength, fracture toughness, and polishability to all be high. So that's how we evaluate composite materials for their longevity. So again, if we look at 2 different types of materials, the first would be a material like a flowable composite that has very low filler content. It has very low viscosity, meaning it's very flowable. Its water absorption is going to be high. Its shrinkage is going to be high. Its flexural strength is low. Its fracture toughness is low. And again, its viscosity is low. So most of us, I was going to say all of us, but most of us use flowable composites in our dental practices. And there are very appropriate reasons for using flowable composites in our dental practices. But the reality is that the flexural strength, fracture toughness of these materials is low, and water absorption shrinkage tends to be high. So we have to be using these materials in places, understanding what the characteristics are. If we look at the newest hybrid materials, we know that the filler content is increased, and with that comes a decrease in water absorption, a decrease in shrinkage, an increase in flexural strength, and an increase in fracture toughness. The challenge of these types of materials is that they're more viscous, and therefore handling characteristics can sometimes be a challenge. And therefore, the challenge for any developer of composite materials, any manufacturer of composite materials, is they're trying to balance handling and physical properties all at the same time. So we want the physical properties to be, again, structurally sound, and yet we want to be able to place these materials in ways that make it easier for us to manage them as dentists. And what the dental industry has done is that they have figured out how to increase the amount of filler, and by changing the size and shape of the particles, mainly using nano hybrids, nanoparticles, they can maintain the physical properties and maintain the handling properties that we are looking for. So that's kind of a review of where we're at with regards to materials and handling, and mainly the 2 different types of composite materials that are out there, some that are more viscous, some that are less viscous, and we're looking for a balance in that. With regards to color matching is always an interesting topic because we constantly think of or at least our profession does, of I want to match the shade of a tooth. And when you look at how to make teeth look like teeth, the first 5 characteristics, silhouette, surface morphology, value, translucency, and chroma, all have more to do, have a higher correlation with making teeth look like teeth. And actually, hue or shade is number 6. So the point that I want to try and make for folks is that ultimately color matching is super important, and yet we can't forget things like surface morphology and the shapes of teeth, making sure the line angles are in the right places, making sure the silhouette of the tooth is in the right place with regards to how we're shaping teeth, and not just think that the most important thing is always going to be the shade. So there are lots of ways that we can make teeth look like teeth, and we can even be a shade off or a half a shade off with the composite materials that we use if we get these other 5 characteristics correct. What are some tips and tricks with regards to managing chroma and hue when you get to that point, when you have the surface morphology and the silhouette and stuff taken care of? What are the things to pay attention to? With regards to chroma and hue, the best way that I know how to manage these sorts of situations is to make sure I'm working with clean and dry teeth. I actually use the camera as a guide, and I'm taking my image from about 60 degrees vertical to the surface of the teeth, using a neutral density gray card, and just making sure that I'm using sometimes multiple shade tabs at the same time is one of the best ways. Photography is one of the best ways to work to become better at matching chroma and hue. And again, surface morphology is very important with regards to making teeth look like teeth, because the surface texture affects light transmission, including reflection and refraction. And so we can tease the eye by just changing a bit of surface morphology, and all of a sudden our teeth look more like teeth. What are other guides that we can use? Tokuyama, I think, has an excellent shade guide. This happens to be a shade guide used with their Estelite products and Estelite composite products, and having this as a reference, this may be better from a composite standpoint than a Vita shade guide with regards to accuracy. And if you use corrected lights in your treatment rooms, if you use a standard flash intensity on a camera that's made for dental photography, you'll get a color corrected light. Place the shade or take the shade before you do any preparation and desiccate any tooth structure by applying the rubber dam, or just even prepping teeth changes the dryness of teeth. And if ever in doubt, the camera oftentimes is the best way for me personally to evaluate shade, because there's just something about the camera that improves my diagnostic capabilities. So when it comes to where are we at in the world of typical composites and across manufacturers, there are certainly multiple companies, multiple manufacturers that make multi-layer systems. Filtech is one, Premise is another, Estelite is another. There are a number of companies that use one-layer systems. Again, Estelite, Sigma Quick, TPH, Spectra. all of these universal composites in the marketplace have multiple shades, and you can see how many different shades that they have to match the existing composites that are out there. And what's unique today about Omnichroma from Tokuyama is that it is the first universal composite that offers one shade of material in a compule that will match any patient in almost every case across the whole Vita spectrum from A1 to A4. And how is that happening? I mean, what is unique about Omnichroma that is different than what's happening in the rest of the world with regards to composite technology and shape matching technology? For most composites today, they're comprised, with red and yellow dyes or pigments that are actually added to the resin material to emulate shades. And Omnichroma goes about this differently. They use what they call smart chromatic technology. And Omnichroma uses a structural color where the fillers are the exact size and shape needed to generate red to yellow color as ambient light passes through the composite. And they can do this without needing to add pigments or dyes. And therefore, this red to yellow color generated by the filler material combines with the reflected color of the patient's surrounding dentition, and this creates the shade matching. So from again, kind of summarizing, all other composite materials out there use red, yellow dyes added to the resin material to mimic shade, and Omnichroma has structural color, so there's actually the fillers are the size and shape of the red and yellow color, and therefore they use the existing tooth shade to mimic. So if you look across the bottom, what you see are various shades of teeth, all with the same, all filled in a class 1, with a class 1 restoration, all with the same single shade of Omnichroma. So you can see the differences between those different colors of teeth, surrounding teeth, and yet the restorations are all identical. So in a posterior situation from a clinical procedure for Omnichroma, you have your preparation that you bevel enamel edges, you apply your bonding agent, light cure, fill with Omnichroma, light cure depending upon the intensity of your light, and then finish and polish. If you're doing an anterior tooth, again, you have your preparation, you bevel your margins, and certainly beveling margins, no matter what material you use, beveling margins is a way to blend aesthetically, and Omnichroma uses that same type of clinical technique. You apply, once you have prepared your anterior tooth and beveled, you apply your bonding agent, fill with Omnichroma. One of the things that you'll notice with Omnichroma is that prior to curing, you're gonna see that it has a very opaque white shade, and that does allow for higher visibility and easier placement. But what you'll find as soon as you cure it, obviously it provides the match to the surrounding tooth structure. So once you've cured the material on an anterior tooth and you finish and polish, you get a similar type of restoration. So what does it look like in my practice? What are the things that I think of with regards to keys to adhesion? The first is that as I manage my tooth preparation with both high speeds or low speed hand pieces, once I'm done with that, I make sure that I clean the tooth structure and all the bevels and stuff, I clean them with a sandblasting. There's two ways. I think the two most common ways to use them are to use like a Danville micro etcher, and in my practice, I actually use the Etch Master from Groman Dental, 50 micron aluminum oxide in a disposable tip, and I have found that that really cleans up the enamel surface and the dentin surface really well. I believe it improves bonding, but it also improves the aesthetic result. Another key to dentin adhesion is to make sure that you are not over etching with phosphoric acid. 15 seconds is with 37% phosphoric acid would be my recommendation. In my practice, I really am careful about over drying, and in each of the treatment rooms in my practice, I use an 8-edge dryer to dry the surface of the teeth appropriately. I don't want to over dry. And then, of course, I want to use materials that are appropriate for the clinical application being performed. So the type of composite materials that I use, the curing depths and all those things, I want to be appropriate with the material that's being used. Ultimately, I want to make sure that I create the appropriate hybrid zone. The hybrid zone is the transition between the resin and the dentin with regards to dentin adhesion. And so how do we create an effective hybrid zone? I believe that we need to pay attention to a couple things. First of all, we need to remove or disrupt the smear layer. A total etch system using phosphoric acid is going to remove the smear layer completely. A self-etch system is going to disrupt it. So either of those two ways of managing dentin adhesion, I believe, are appropriate. Self-etch systems are absolutely appropriate with dentin adhesion, as are total etch systems. It just depends on what your preference is, but I want you to understand kind of how those two systems differ. And in creating an effective hybrid zone, you're going to use a primer resin in a solvent. Tokiyama's Bound Force dentin adhesion uses an alcohol solvent. And basically, you're going to carry your resin and infiltrate the dentinal tubules using your dentin adhesion. So the acid is going to demineralize the dentin tubules from your phosphoric acid or your self-etch dentin adhesion system, and your primer is going to carry your hydrophilic resin with a solvent into the dentinal tubules. What are the risks? What are the things that we want to avoid? On the left is an appropriate matrix, an electron micrograph of what we want dentinal tube structure to look like. One of the risks is over etching, which you see on the right. The other risk is over drying. So these images are comparing and contrasting what we want on the left and what we don't want on the right to make sure that our materials that we are going to create the most effective hybrid zone. So what are some advantages to self-etch one-step systems like Tokiyama's Bond Force? I believe the advantages are fewer steps and less clinical time. There's less room for error. I believe self-etch systems are excellent with post-op sensitivity. What are the disadvantages? They have good bond strength, not excellent bond strength. And one of the things that you can do is pre-etch enamel surfaces and aerobraid enamel are all ways to help improve the bond strength. And depending upon the system that you're using, it may or may not be compatible with different core pastes and things like that. So make sure that you are using manufacturer-specific dental bonding agents and composite materials. And certainly, the different, whether you use total etch or self-etch systems, they all have various ways that they are effective. So in my practice, when I think of the my technique and what are the things that I'm going to pay attention to. I'm going to prepare, I'm going to bevel, I'm going to sandblast, I'm going to etch, I'm going to bond, I'm going to place composite, and I'm going to polish. So I'm going to take you through some examples of omnichroma in these clinical situations. So the first clinical situation that I'm sharing with you is the restoration of two lingual amalgams, one on a central incisor, one on a lateral. And if you look at these four restorations, two of them I believe are sound, two of them I believe have been compromised with recurrent decay. So these were the two preparations that were made. And in this case, they have been prepared, the enamel has been beveled, we have sandblasted, we have etched. So now it's about placing bond, composite, and polishing. And one of the things with any composite material that you use, one of the concerns is with discolored natural two structure. So the amalgam, even though all the decay has been removed, the dentin has been stained. And one of the advantages of omnichroma system is they make a specific blocker material, an opaque blocker composite, resin-based restorative material. And in this clinical situation, I placed the blocker because I wanted to block out, I wanted to use the opaqueness of this blocker material to block out the color of the stained dentin. So the blocker was used, and then omnichroma was placed over top of the blocker material, and it was polished. And you can see the match of the lingual composite, or excuse me, match of the lingual enamel on these teeth, and look at the difference in the color between the central incisor and the lateral incisor. The central incisor is a lot darker than the lateral incisor, and yet the same composite was used in this, and the color looks accurate on each of those. So I am in Western North Carolina. I have some patients who aren't as effective with their home care. Maybe you have patients in your practice that are like this. Sometimes when patients tell me they use their toothbrush, I wonder about what end of the toothbrush they're using. But this patient had lots of anterior interproximal decay. This happens to be a preparation of a right lateral maxillary incisor. You can see there's the darker coloration around kind of the cervical one half of this tooth. A clear matrix is placed. It's wedged from the lingual. The preparation is made. It's sandblasted. It's etched. The bonding agent is placed. Omnichroma is placed and cured, and this is kind of the shade of the final restoration. Again, to me, it looks like an excellent shade match to the existing tooth structure. This is actually the same patient on the contralateral side, so the other lateral incisor preparation looks very much the same. It's the area of this tooth structure, cervical one, I guess one half, cervical half has, again, that same darker discoloration. The tooth has been prepped, sandblasted, etched, matrix is placed, and this again is the color coming from the omnichroma. Again, keep in mind that silhouette and value and all those things are taken into consideration, but the match of the material to me looks excellent. Different clinical situation with a patient with class 5 non-carious cervical lesion. It appears like 8 years earlier that the canine tooth was treated. There's a small area of staining along the edge of the canine tooth, but you'll see the existing non-cervical carious lesion on the premolar. We placed a small retraction cord, prep, bevel, sandblast, etched, placed our Omnichroma material, finished and polished. Again, I think the color characteristics of the Omnichroma and how its ability to have like a chameleon effect on the surface of the tooth. In a clinical shade, this is probably like a C3 or a C4. So its ability over time to mimic the natural tooth structure is excellent. Just as an aside, I polished the canine tooth. The restoration, I didn't have to replace it. I just needed to clean up around the edges of the tooth, and the patient thought that was an excellent outcome. So another clinical example, this is a class 2 decay on a lower premolar, and the preparation, rubber dam was placed, preparation was made, enamel was beveled. I tried to be as conservative in the class 2 preparation and the occlusal preparation as possible. Tooth again sandblasted. I used a Garrison matrix system to isolate the tooth. This was a selective etch technique. So I selective etched the enamel. I placed my Tokiyama bond force dental adhesion system, placed my Omnichroma in 2 different layers. Omnichroma should be cured in 2 millimeter increments. So that was about a 4 millimeter depth. So it was placed in 2 increments and finished and polished. And there is an inclusion check, and there's the final restoration with regards to the aesthetics of this material and how, again, it mimics and chameleons with the shape of the tooth structure. So what I will say with regards to my wish list for composite materials, if I came back to this image one more time, that that from the standpoint of wanting fewer steps for placement, I think Omnichroma certainly fits that bill. Less inventory. It's nice not to be having to keep the shelves stocked with multiple shades of composites. I do believe it's highly aesthetic. I do believe my experience is that it is going to be durable over time. And I guess an added benefit of this type of material is that even if the patient, if you have restorations on anterior teeth that are visible when the patient bleaches, remember the color from the composite material is coming from the surrounding tooth structures, so you have the benefit of anterior composites that are going to hold up better with bleaching over time, as opposed to placing the patient with a standard composite material and the patient bleaching, and then your composite not looking as nice. So some last things to consider with regards to composite materials and the longevity of any composite material placed is going to be based upon your success at curing that material. Some of you that have curing lights that are similar to the image on the left, the tungsten halogen type systems, unfortunately those types of curing lights today don't provide the intensity, the same amount of intensity that the newer systems do. Therefore, you have to be curing for a lot longer. And in my world, I believe that those curing intensities degrade much faster over time. The halogen bulb doesn't last as long, doesn't kick out as much power a year from now as it does when a new bulb is placed. So just make sure that you're testing your curing lights, because unfortunately the surface of your composite could be cured, but the reality is that deeper down into your class 2 areas, your composite may not be getting cured, and therefore the patient could have increased risk of sensitivity, recurrent decay, those sorts of things. So make sure that your curing system is appropriate. Obviously, that each composite has a required dosage. So if your light intensity is 400 milliwatts, you have to cure in order to have the required dosage for that composite. You have to cure for 20 seconds versus the newer light systems that use much higher intensity. You can cure for a lot less. Have your curing lights tested, test them on a regular basis, particularly those that use a halogen system, because they do not cure with the same intensity, of course. And lastly, the depth of the composite curing is going to be directly related to the intensity and duration of the light exposure, and the further distance that you have that curing light from your composite, the less likely you are to be able to cure and do it well. There are fantastic small form curing lights that are used today. This is an example of one here. It has an intensity recommended at 1200 milliwatts, and you can get 10 seconds per increment on composite, or 10 seconds per millimeter of ceramic, and those things work well. So the course objectives that I wanted to be able to handle for today was that we would examine the best practices to shade match anterior teeth. So think about silhouette and value and surface texture, and not just the hue or the color of a tooth. I wanted to share with you a review of composite materials and techniques that produce the most natural looking restorations. And depending upon the handling characteristics that are out there, and kind of the newest composite materials that are out there, I believe that you can achieve these, and that by understanding the characteristics of modern composite materials and how they contribute to efficiency, you can be a clinician who is more efficient and more effective with your composite techniques. So I want to thank everyone for attending. Matt, I'm going to pass this back to you so that we can go through some questions. And thanks again for all of you that are attending.